under what a lot of the modeling projections that are out there said that we'd be at right now. Unfortunately, we've had 4 total deaths. If you look at the incidence curve, which means the number of new infections per day in the US, we had exponential growth up until the last few days, and it seems to be flattening for the US overall. In North Dakota, we've been flat all along. We've certainly not had exponential growth. We've not even had linear growth. We've been pretty flat. So knock on wood, that stays that way and we stay ahead of the curve. I'll probably just stop with that. And I'm sure there's a lot of you here to answer questions with, and I want to spend most of my time getting at what you want to ask.
All right, perfect. Chris, do you want to get us started off?
Sure. I guess my first question, maybe you'll know about it. I just saw something that said they're using plasma therapy in South Korea to potentially treat severe COVID cases. Is that something that maybe the U.S. could start implementing, or is there any promise to that?
The answer is yes to both questions. Red Cross, Vitalant, and a number of the other plasma collection companies and services are rapidly ramping up to be able to test and be able to offer that. So they will identify plasma donors that have antibodies. And the idea behind this is that you are trying to collect plasma from people who had the infection, recovered, and have made antibodies. And then you infuse that plasma into a person with a new infection and hope that those antibodies will help them fight that infection. So there's been actually a great deal of work amongst the healthcare systems and the blood donation or plasma donation services to get that ready to go and to be able to identify convalescent potential donors.
And then, we see a lot of death and we see a lot of people getting this disease, but now it seems like we're hearing more in the news about how many new treatment options there are. So I guess maybe some words of, is there hope for new treatment options coming along?
Yes. So I think there's actually, it's interesting seeing attention being given to a lot of old drugs that we've had. I think we've talked about this a little bit before. Chloroquine and hydroxychloroquine are drugs that have been around a long time to treat malaria and various rheumatologic diseases. We have access to those now. There's in the test tube and some kind of preliminary data that suggests those might be helpful. There's a plethora of clinical trials now trying to evaluate that in a much more robust way. And then I think one of the more promising drugs, which is in kind of the middle of what we call phase 3 trials, which is the last set of clinical trials before clearing FDA approval, is a drug called remdesivir from a company called Gilead. That has a good theoretic potential to be able to help, and we should see that clinical data come out, I think, pretty soon. And if that looks promising, that drug could be available, I think, as early as a couple of months. There's been attention to some older drugs, again, an antiparasitic drug called ivermectin. Again, sort of test tube data showing that it maybe impedes viral entry into the cell. Really uncertain whether that's going to be a benefit. So, but a lot of high throughput trials being ramped up very fast to answer those questions and develop new drugs. So I think it's possible we will have several therapeutic agents that may help within months. I will say though that finding a blockbuster antiviral drug is rare. It's uncommon to find a drug that just shuts everything down and is an immediate cure, like we kind of have more with antibiotics for bacteria. Most of the time, antiviral drugs kind of slow things down and maybe attenuate the disease.
And I guess my final question, we've been in this kind of driving in this dark tunnel for a while. Are we finally starting to kind of see that light at the end, or if we're not, how long till we get there?
So we are seeing clearly the curve flattened or the curve bent, like we heard a lot about, in the last few weeks. Most of Europe is clearly on the downhill side of this. US is now starting to flatten and drop. That's all good news, but it has come with a terrible cost. All of us hunker down in our homes, businesses closed, people filing for unemployment. I mean, these are going to take their own toll, even on both mental and physical health. And we're going to have to figure out a way to balance those things very soon. And to be honest, there's really only one of three ways out of this. It is herd immunity through natural infection, or herd immunity through vaccination, or a blockbuster drug, or some combination of the three. Now, herd immunity means the number of people in a population that are immune at a threshold that will stop propagation of the disease. The estimate for this coronavirus, SARS-CoV-2, is that we need somewhere between 50 to 70% of the population immune to stop transmission. We need to get there either through enough people having gotten it or a vaccination that gets us there. And I think we also have to be realistic about vaccination prospects, because you hear 12 to 18 months, but a good proportion of vaccines don't make it through all the clinical trials. They fail somewhere along the way. So we're going to have hard discussions here after we get our breathing space now, which we're getting. We're able to catch our breath here because we've, as we said, kind of flattened the curve and given our hospitals chance to manage these. But now we're going to have hard conversations about how we get through this going forward.
Thank you so much. That's all the questions I have.
Sure. And Dave, right?
Yep.
Yes. So the governor has been taking a little bit of a heat for not issuing a stay-at-home order, and as best anecdotally, it seems like it's coming more from out of state than people in state. But one thing he said is that he hasn't seen any data that shows that, and he's, to be fair, he's put in a lot of orders, which according to his office, Dr. Fauci says has been as good as a stay-at-home order. But he hasn't seen any data that shows that a stay-at-home order is making any bigger of a difference than those that haven't, along with, the measures he's taking. What's your thought on that?
A few thoughts. I think the out-of-state calls for telling us kind of what to do in North Dakota should be really driven by data. And here's the data: we're amongst the 10 best states in the country for testing per population, and we're amongst the 5 best states in the country for deaths per population. I think people should maybe ask North Dakota what they're doing to be so successful on those two fronts. Those are the measures to really look at. If those change, if our curve wasn't flat, if we were in exponential growth here, or we were amongst the 5 or 10 or 15 worst states for either testing or deaths or cases, I think then there'd be some legitimate criticism. Until we see that, I think what we're doing is probably appropriate.
So I was talking to some spokespeople at the Border Patrol. Mainly, I was trying to find out the traffic there, and obviously it's down, and what they're doing to protect their employees. One thing I found out is they're not testing their employees at the Border Patrol. That they're having them go through the same routine a citizen would. Is it unrealistic to expect some of these government agencies to test all their people?
So you're talking about testing the workers themselves, like as
they're not, right?
I'm very circumspect about using the current testing methods we have to sort of randomly test or screen asymptomatic groups of people. The only place I might think about that would be healthcare workers, because you have to understand what the test that we have now does. It will only capture a person who is in the midst of actively shedding virus. And you can test that person one day and they're negative, and the very next day they're positive. And in fact, you would get a false sense of assurance if they were negative to say, well, we know you're in the clear, you're good to be working. What we really need to do is be very vigorous about asking in important in jobs and situations where they might be face to face with a lot of people, is to ask daily, Have you had any fevers, chills, sore throat, cough, shortness of breath, taking a temperature? I mean, that's what we're doing in all of our nursing homes. That's what we're doing in our healthcare systems. That's what a number of other essential businesses are doing. And then removing those people immediately if they screen positive. I think we could burn through lots of testing capacity, randomly screening people who have no symptoms. You might pick up a rare person here and there, but you're going to burn through a lot of tests with a lot of negatives for, I think, a false assurance.
A couple other questions. Have you seen Tim Brooken's Care 19 app?
I have not.
You have not, okay. He just unveiled that the other day. It's kind of a contact tracing app.
Yeah, is this the modification of the Bison Tracker app?
Yes, correct, yes.
So I think it's a great idea. I haven't seen it or played with it. We've been talking about that, but I'll tell you, that's what has been part of South Korea's great success is, some of I think the Asian countries are a little more willing to forego, deep privacy concerns to, for the common good. It's a little bit dicier, I think, in the United States. But I think if people are voluntarily willing to do that, it will facilitate notification that, look, we see there was a positive case here. We can see that you were around that case on such and such a date. You should quarantine and report immediately for any testing. That type of technology has been very successful in certainly South Korea and some of the other Asian countries at really improving their traditional contact tracing, which is asking people, who were you around? Do you remember where you were, what you did, which often misses a lot of contacts.
Yeah, in fact, I received an overseas email from a company that said their app is a lot better. And you should do a story on this, but that's beside the point. Lastly, I'm asking a question about the outdoors, and Governor Burgum yesterday is kind of encouraging hunters and anglers from Minnesota to come on over and participate in our seasons, which they usually do. With fishing, Devil's Lake is really popular for Minnesota residents, and I think that's a ways off yet, the fishing opener. But do you agree that that's really doesn't pose much of a danger?
Depends on how it's done. So certainly being outdoors is not a danger. Being standing on the shore in a boat on a lake is not a danger. Being out in the field hunting, ducks, geese, upland game is not a danger. It's the people that you're with that put you at risk. So if you're going with all your hunting buddies, 10 of you gathering in a cabin somewhere or something, that does put you at risk. But if it's your own family who you're housed with anyway, if it's you yourself, if it's small or minimal numbers of groups where you've been, pretty safe, I don't see that as posing much risk at all. And I frankly am personally anxious to be doing some things outdoors myself soon. And and we also know, respiratory droplets, which is the means of transmission, really disperse quickly in the outdoors. I mean, it's a much, if you're going to be around or anywhere near other people, it's better outdoors than it is indoors.
And is that Bison Oregon game going to be played in September?
Oh gosh, I get asked these predictions a lot about football. I hope, all I will say is this: I really hope so.
Okay, thank you.
Thanks, Dave. We will go to Nick with WDAY next.
All right, Dr. Carson, thank you again for your time. First question I have, we're seeing more people with this notion that we should just get back to where the economy is taking too much a hit, basically implying that we should kind of see that as a more important priority than public health. What are your thoughts on that, and people who have kind of written articles, editorials, et cetera, about that?
Yeah, sorry, JJ, you're cutting out a teeny bit on me, but I think I got the gist of the question. So, the questions about the importance of getting the economy back going and, people back to work and so on. And the way you frame the question is, in opposition to public health. And actually, as I kind of alluded to at the top with Chris, is that I don't think these are in opposition. When you have mass joblessness, when you have prolonged social isolation are independent social determinants of health that have actually pretty potentially significant adverse effects on health. Opioid use and alcoholism increase when you have significant joblessness and isolation. We know that interconnectedness with family and friends is actually quite important to health. And it's, as I said, at some point we are going to need to balance these competing risks for our health. And even though some people may be calling for this, with their concerns about the economy, those things have actually direct impacts on health as well. And I am sympathetic to the idea of that we really probably cannot do a sort of hunker down, businesses closed for 6, 8, 10, 12 months and expect that that won't have dire consequences on not only the economy, but on people both physically and mentally and everything else.
Got it. We're here in nursing homes. I guess with lack of better phrase, using fog to kill virus, to kill bacteria in their nursing homes. Is this, in your mind, an effective way to make nursing safe? Is it something that we should be seeing more of? Or?
I don't know enough about what that specifically is. I actually consult for a couple nursing homes on infection prevention. I was sent by the CEO of one of the nursing homes I work with a device that's made out of a company in Minnesota that fogs the environment. It depends on, and I couldn't find what that fog was. We do know that there are devices that, for example, emit something called hydrogen peroxide vapor, and it may be that that's what they're talking about. That does work to help kill bacteria and viruses, and may help in the fight with this. It's not at all unreasonable to be looking at that. But I will say this, that the environment as an infectious source plays a role, but it is probably a minor player in transmission. It's much more important on how we manage the infected person and their ejection of droplets and the personal protective equipment that the workers caring for them have access to and use. That's probably far more important. But I don't discount that, and it's worth looking at. And I know a lot of health systems are looking at enhanced disinfection. But to be fair, almost all the cleaning agents we use in typically healthcare settings and nursing home settings kill the virus just fine. So just good cleaning will do it.
All right. And then we're hearing more about potential long-term heart conditions in otherwise healthy people who have recovered from coronavirus, but there's still some lingering effects in their heart. More places seem to be talking about it now. What do you know about it? And tell us more about kind of what we know so far about the potential long-lasting hearts.
Yeah, only a little. There's only been a small amount of published research on the long-term effects. It does appear that some people, end up with more long-lasting debility, weakness, physically difficulty recovering, some chronic lung issues, decreased lung capacity, longer reliance on oxygen. That's not uncommon after any severe illness, and sometimes it takes prolonged rehab to get through and get out of any severe illness, but I think the jury is still out. We are also learning that it sometimes has rare other effects other than on the lungs. There's been a handful of cases of reports of encephalitis or inflammation of the brain that's been pretty dramatic. There's been some reports of direct effects on the heart. These tend to be a minority of cases, but there's more and more reports of this popping up. So it does apparently do more than just cause a respiratory illness in some people.
Yeah, and another thing that I've heard is that some are saying if you think you have it and you can't get a test, the treatment is still the same. You're going to be asked to isolate at home. Much a difference whether or not you get a test in terms of how you're treated. Is that something that you know about?
I am so glad you asked this question because I think I forgot to bring it up last time. So in North Dakota, we are in better shape for testing than almost any state around us and many of the other states in the country. If you are sick, get tested. We can get you tested. We don't have a shortage of testing supplies. The health systems now are ramped up. The health department has significantly increased capacity. I will thank the governor and his team for that. They've been very aggressive about getting us machines, equipment, and reagents to test. We want people tested if they are sick, and that's with any kind of respiratory or viral, upper respiratory or lower respiratory symptoms. And the reason is, I mean, you can argue that, well, we're going to manage it the same. You go home and you stay in isolation. But what's different is if we know you're positive, we will hunt down all of your contacts and make sure that they're being watched carefully and tested promptly should they start to develop any symptoms. And that's basic traditional public health 101 is case finding, contact tracing, quarantining the exposed, isolating the sick. And so we want people tested. In North Dakota, they can get tested. So thanks for asking that question. Appreciate that.
Yeah, no problem. So it seems like that's kind of in the interest of public health as a whole to get tested, just for the one particular patient.
Definitely.
Gotcha. Last question. Obviously, we all don't have a crystal ball in front of us. I'm hearing people say that they're hoping that things get quote unquote back to normal by June. Does that seem like a realistic month to you, or is this just way out there? Like we have no idea when this is going to get back.
So what I would expect is we will be over the crest here in probably the next 4 weeks. We will be down in most of the states, I think, to a much lower baseline level because of these extreme social isolation measures. Then we will be having, I think, a public debate about how much, where, and when to start relaxing strictures. And summer may bring some relief as well. There's a big debate about whether even just summer itself would bring some relief to this. I'm of the camp that believes it will. But that doesn't mean it's going to be gone, and that doesn't mean it's going to be life back to normal. It's going to be some kind of attenuated life here of how to get some things back to normal or a closer semblance of normal while still protecting the most vulnerable, the elderly, the people with chronic medical conditions who are at the most risk. I don't think we're going to look like normal for a while until we get to herd immunity. And the big key to that, I keep hammering on that point. The big key to that is, as I said, enough people who've gone through infection, we have enough immunity. But one of the things we can hope for, and that we hope to answer soon, we're going to be doing some research on this through the health department, is to do antibody testing on representative samples of the population. Because if we find, for example, that for every sick person that gets this, there's 10 other people who got it without any symptoms, well, hallelujah, we've got a lot of people who are getting immune out there without having to pay a serious cost. And then your strategy might be kind of a slow burn of this so that lots of people are getting immune and we get to that, 50, 60, 70%. We hope to answer some of those questions in the next few months about how many asymptomatic people have been infected and are now immune.
All right. All right. Well, thanks so much, Dr. Carson. I think all that I had on my end.
Okay.
Thanks, Nick. All right, we will go to KFGO to finish us off.
Hi, Dr. Carson, Amy Eiler, and JJ Gordon here. You were just touching on the first question I had for you, and that was about the test for antibodies. And can you speak to the 3 asymptomatic cases that were found in rural North Dakota that the governor announced yesterday?
Sure. So that was with a pretty big screening effort. I think over 700 people were screened, and so if you kind of look, I think that found about 0.8% of the people that they screened were positive shedding virus. We'll have to kind of put our thinking caps on as to what to learn from that. That's not a big number. The 3 of the 6 would have been picked up if we would have had aggressive testing of symptomatic people. What we are usually finding is that you can identify people that shed virus sometimes without symptoms, but most of them appear to then develop symptoms within the next few days. So I don't know that I would call those as yet asymptomatic cases. Those 3 may have been pre-symptomatic. But antibody testing will answer that question for us. It will teach us how much true asymptomatic infection is out there. The PCR test, which actually tests for viral RNA, is a blunt instrument to try and figure that out, because you got such a narrow snapshot of time to capture the positive person.
Dr. Carson, when it comes to developing a vaccine, who is actually developing this? Are we talking about a government agency is working on it? Are private drug companies working on it? And if private drug companies are working on it, I mean, what's the likelihood we could see something close to what's happening with insulin in the country right now?
So the answer is yes to both of the first 2 things. Both NIH-sponsored vaccine trials and industry development are both occurring, and several of them are public-private affiliations and partnerships to develop vaccines. I think if it relies, this is actually something we debate in my classes, like how to have proper policy when it comes to infectious disease related vaccines and therapeutics. The current model that we have, which is really a market-driven approach, kind of fails us when it comes to a lot of these vaccines and therapeutics. I mean, SARS, for example, the original SARS, exploded on the scene. There was a whole bunch of investment in vaccines and development of potential therapeutics, and then it disappeared, and all of those projects were abandoned. They weren't carried out, and it was a big disincentive to a lot of companies to not invest in that thing. This could similarly happen with this one, although I think there's a much more interest to have government investment in something that can last and be durable and is not purely market driven, because the market will fluctuate with how bad the disease is. And we need models and changes in policy that will allow for predictable and reliable vaccine production.
I think a lot of my other questions were answered, but can you sort of speak to this narrative about how many states are competing for supplies? You've made it clear that North Dakota is in a good position with its testing equipment and other hospital equipment, but you don't hear that from other states, and you hear people like New York Governor Cuomo sort of taking to task the fact that he's having to bid on supplies like he would on eBay.
Yeah, it's an interesting phenomenon, and it's something that I've kind of learned, through all of this, that in some respects, some things are kind of assisted and aided at a federal level, but in many respects, states are kind of their own island, having to try and work and compete for some of these resources. And I think we'll see after this a lot more high-level discussions about how to manage this in a more coordinated way for the country, as opposed to each state kind of vying for their own resources. It's an important question, and I think an important debate that we're going to have in the near future on all of this.
Can I double back to the summer just for a moment? So what is it about summer that we think will flatten the curve?
Yeah, so it's a bit theoretical, but it's there's reason to believe this is correct. There's 2 things. So we see this certainly with most of the respiratory viruses. They have a seasonality that tends to increase in the winter and decrease in the summer months. 2 main reasons for that. One is that kids are out of school. With things like influenza and most of the respiratory viruses, kids are little incubators for these things and are often the driving spreaders in the community. And so when you kind of separate them from each other and they're not congregated day to day, that reservoir and ready transmission of a lot of these markedly diminishes. The other thing is that we know with respiratory droplets, when you cough, sneeze, even talk, a variety of sizes of droplets get ejected out into the air around you. And when we are in the summer, when it's more humid, those droplets take on more water and they plump up and they then fall to the ground quicker. Where in the winter, or the air is very dry, they tend to desiccate very quickly, which allows them to stay suspended in the air for more prolonged periods of time. And so there's both environmental and people interaction reasons why we think that's the case.
Could you also give us a definition of herd immunity?
Sure. So the definition of herd immunity is the level of the population that needs to be immune to stop a virus or other infection from being able to spread in a community. So when you hit that threshold, it effectively stops the epidemic potential of the infectious agent. And that's completely dependent on how contagious that thing is. So for example, with measles, one of the most highly infectious viruses we know, you'll see on average about 14 or 15 people getting infected for every single case. And in fact, if you've got a classroom full of susceptible people, 90 to 95% of people will acquire that if one infected person walks in the room. Contrast that with SARS-CoV-2, coronavirus, it's about maybe 2 to 2.5 people will get infected for every single person that carries the virus. With measles, we need 95% of the population immune to hit that herd immunity threshold. With SARS coronavirus 2, we only need about maybe 60% of the population immune to stop spread.
So do we look at that as a global population, as a nationwide population, as a state population?
That's a good question. It will work at probably any of those levels. So it is, as much as you have a population or congregation of people who are maintaining that herd immunity threshold, it will not spread in that population. But if you start to dilute that, on the margins or whatever, it will have a chance to spread. Ideally, we would like to see that at the global level. And again, we only get there through natural infection or vaccination. But it will work even at the smaller level as long as that threshold is maintained.
And lastly, I want to talk about a conversation I've had with a lot of people who have at this point convinced themselves that they had COVID-19 earlier in the year. And at the time, they thought it was bronchitis. They thought they just had a case of the flu. They had a bad cold, whatever it happens to be. Do you think that there is a possibility that a decent percentage of the population has already had it? We just didn't know at the time?
Yes, and that's a great question. So what I hope is that in the next couple of months, just like our governor and his team have gotten us pretty darn good testing capability for, viral detection, that we get that same robust testing capability for antibodies. I want all of those people to show up and get tested for antibodies, and we can answer that. Did you have it or not? And here's what we could envision. That we start identifying more and more people who are immune, and we say, you're ready to go back into the workforce. You can go be the front person as the bank teller or the grocery store clerk or the healthcare worker. You might even picture, like, do we have some kind of badge or wristband or something that identifies you, or a card that says, I'm cleared, I'm immune, I'm ready to serve you without you needing to be afraid to be around me.
Thank you very much, Dr. Carson. We appreciate it as always.
You're welcome. Any questions from anyone else? I don't know if that works to take it out of sequence again, but I'm happy to answer any other questions if you have any.
I think KFGO should turn on their camera next time.
Dave, we're in radio, so get off it. I've been getting your text messages, and we're in radio.
I don't trust people I can't see. I'm just
So
saying.
just blanket across the board. You don't trust people in radio then? I mean, you work with us.
No, I trust Joel Heitkamp, but I'm kidding.
Real
silly.
professional of the AP to be wearing a cap during the interview, by the way. Just throwing that one out there.
All right, how's this?
Looks like
Okay,
me.
too much reflection. Put the cap back on.
Thanks, everybody. Thanks, Bryn. Thanks for putting this together again.
Yeah, thank you.
Everyone, appreciate it.
Thank you.
Thanks, everyone.